Okay. Yeah, Joyance, you can start and then.
Good morning, everybody. Welcome to another session of the pediatric foot module. Today, the topic is Clubfoot, Ponseti's technique for Clubfoot, basics and beyond. Although Clubfoot is, I think, every pedipod's bread and butter, but it's one of the most essential techniques that each one of us needs to learn. And today we have Maulin sir to teach us about the basics and beyond of this technique. Sir does not require any introduction. Since the beginning of this teaching module, Sir has been there. And okay, so I'll just ask Sir to take over the screen.
Yeah, thank you. Thank you, Joyance. And I remember my mentors used to tell me that if you want to do pediatric orthopedic practice, you learn clubfoot first because the clubfoot gives you the practice. And I remember that I treated first clubfoot child, and that child brought up scoliosis patient on the next visit. That so you corrected my child's 90-degree bent foot, so you can correct this spinal curvature. So that's how your practice starts. I know that we all know clubfoot management of Ponseti technique. I was fortunate to learn this from the master himself and could visit Dr. Ponseti at Iowa in 2006. The technique which has come to us through different layers has changed a bit. That's what I see. I will try and teach you what I learned during my stay with Dr. Ponseti. I would like Joyance or Tashfin, you can mute if some delegate has accidentally kept their mic on.
Yes, sir.
So, clubfoot, we all know that the club word has come from the bottom of the golf stick. The shape resembles to the bottom of the golf stick, and that's why that is known as club, and the foot is termed as clubfoot. Now, this patient was referred to me with a diagnosis of bilateral club feet, but uh, I always tell my fellows that the clubfoot diagnosis is not by inspection, but by palpation and to see the corrections which we can have with the passive stretching. So apparently it looks like bilateral club feet, a severe one in some. My videos are not playing through the PowerPoint, so I'll just move out and I'll share the video. So can you see that video, Joanne?
No, sir. No, sir. No, sir. So your PowerPoint screen is being shared.
Joanne?
Yes, sir.
Hello.
Yes, sir.
You can see the slide?
Sir, I can see the slide.
Okay, I tried to run a video. Could you see that?
No, sir.
Okay, let me try again because what I feel is this internet connection here looks little. Can you see the video now,
No, sir.
Joanne?
No, sir. We can not see, sir.
Okay, I'll stop the video and okay. So in nutshell, this were both the patients were postural clubfoot, and we could just parents were advised exercises, and you can see at 3 months, they were all straight. So what I mean is, always don't jump on the diagnosis of clubfoot while just looking at them. They can be a postural deformity. And we all know that the typical clubfoot had four elements: the forefoot cavus, forefoot adduction, hindfoot varus, and equinus. When you approach a child, you must see the severity of the clubfoot. While cavus lies in the different direction than the adduction, varus, and equinus, we have to correct cavus first, and I'll explain to you. The severity is such that the medial plantar cleats sometimes extend on the dorsal side, and they're very severe cavus, and you might need multiple plasters. The severity on equinus you can assess from the number of creases, and many a times it is so severe and stiff you may not find any crease, and the heel is flush to the ankle. So based on this severity, you can gauge the amount of plaster. We all know Pirani scoring system, and this literature is freely available on this global health education, where we score them in a midfoot and hindfoot contracture score. It's a good method to assess the severity of club feet, but unfortunately, this Pirani score will not tell you that how many clubfoot plasters it will require, because a minor deformity may be very stiff, and a very severe looking deformity may be supple. At the end of one plaster, you may see the severe deformity getting corrected. So Pirani scoring is good method of assessment and documentation. However, it is not shown to show you the number of casting or stiffness of the foot. Coming to Ponseti technique, the curves of Ponseti technique is a pathoanatomy of the clubfoot, and this figure is very popular. You will see this in all the presentations. And we know there is medial subluxation of navicular over talar head, making it prominent on the lateral side. And this deformities has a central axis which passes from the superomedial anterior to the posterolateral inferior. And this axis center point is the interosseous membrane between talus and calcaneum. Only one deformity out of four lies out of this axis, which is cavus. And that cavus is due to relative pronation of first and second metatarsal. Clinically, you might see that the foot is in supination, but if you carefully look at the foot from the side and back, you will see the first and second metatarsals are more pronated or plantar flexed compared to the rest lateral three toes. And that's why we need to correct the cavus first. And that can be done by lifting this first and second metatarsal. And once you have corrected the first, the cavus, you have to start correcting the forefoot adduction and hindfoot varus, and equinus also starts correcting together, because all these three deformities lies in the same axis. And you can, as you correct, you will know that there's a combination of gliding, translation, and eversion movement, which is known as kinematic coupling. So all these three things happen together. You have to correct cavus first. Now, if you see very carefully this architect in different position of passive external rotation, when the external rotation is minus 20 degrees, the talar head lies over the calcaneum, and you can feel the talar head at the top. Clinically, Dr. Ponseti always taught that you first feel the fibula lower end, which is very easy to palpate, and then slide your thumb anteriorly. The first bony prominent you feel is a talar head. And what I also found that talar head is more proximal and more central than what we expect. So try to feel fibular head first, the fibular lower end, and then slide your thumb in front, and then you feel the talar head. So when the talocalcaneal joint is locked, the talar head is felt at the top of your pulp of your thumb and the calcaneum at the bottom. So this relationship is vertical when you start the treatment. And at this point, the calcaneum is locked. What I mean locked means that if at this point you try and attempt correction of equinus by pushing the calcaneum or heel down, it will not allow that correction because calcaneal anterior body cannot go up because it is blocked by talus. And so any attempt to correct equinus at this stage would lead to a false correction at the midfoot level, which very popularly known as midfoot break. Coming to correction when it has happened up to neutral, still this relation is vertical. And when you do passive external rotation beyond certain degrees, you will feel that now that vertical relation has turned horizontal, where you can feel your thumb, which was vertical, now it is horizontal. On the medial side of pulp, you should feel talar head, and the lateral part of your pulp, you should feel calcaneal body. And many a times in complete correction, you will stop feeling the talar head because it reduces completely, and what you feel is just the anterior calcaneal tuberosity, and that is known as unlocking of calcaneum. At this point, if you do TAT anatomy, then you can get correction of equinus because now the calcaneal anterior body has a place to go proximally because it is now not locked by the talar head. So the important key is lying in the clinical feeling of this talocalcaneal joint rather than the passive external rotation. What I see is during different lectures, the timing of TA tenotomy has been decided by the degrees of external rotation, but that is not right because many children, we see that even in 20 degrees of external rotation, talocalcaneal joint gets unlocked. So if you keep on doing external rotation plaster after that, what you develop is a deforming, you are subluxating fibula sometimes posteriorly. So your decision about timing of TA tenotomy should be based on your clinical assessment of talocalcaneal joint rather than the amount of passive external rotation. And as you can see, as you keep on correcting the foot, not only heel varus gets corrected due to the pressure of cuboid over calcaneum, but the distance between the tibia and the calcaneal tuberosity also increases, suggesting that it gives correction of equinus as well. So how to correct cavus? Again, you can see step one, you hold the foot, you hyper supinate, and then you correct the align the first metatarsal with the heel, and that's how you make this cavus corrected. Many a times you need plaster in about 70 degree of supination where cavus is very severe, and you may need two or three plaster just to correct the cavus. And once the cavus start correcting simultaneously, you start rotating the supinated foot externally, keeping your thumb on talar head and not on calcaneocuboid joint because you don't want to uh, uh, block calcaneum by putting the thumb there. So that's a very important thing. And that's why it's important to feel the talar head. You must learn where is the talar head. And it is best felt when you accentuate the deformity, when you put the foot in more inversion, you will feel that. And as you do correct the forefoot adduction, it will come in more and more external rotation. Now remember that there is a rolling and molding technique. So when you wrap the plaster, it has been taught that you have to put your thumb over talar head, but it doesn't mean that you keep your thumb on talar head persistently. It's always a molding technique or multiple punching on the teller head. Otherwise, if you have a persistent pressure, you may end up having injuring the skin and complication like this. So you have to avoid. And I'm showing you a video of Ponseti technique after this presentation, and I'll show you how to do rolling and molding. And as we know, uh, in sequential plasters, by an average 4 to 5 casts are necessary to correct the clubfoot if we start treatment in the first couple of weeks of life. And once the talocalcaneal joint is unlocked and dorsiflexion is less than 15 degrees, we have to do TA tenotomy, and TA tenotomy is done at my place, even at in Iowa under local anesthesia. It's done at 1.5 centimeter above the TA insertion with 15 number blade or beaver's blade. I know that many colleagues, they like to do with a needle. That's also fine. A complete tenotomy needs to be done, and you don't need to suture that millimeter incision. And the average correction is 10 to 15 degrees, and post tenotomy plaster is for 3 weeks. In very stiff club feet, when you do a TA tenotomy and you are not able to achieve dorsiflexion of 15 degrees, you may come back after 10 days and repeat one more plaster and stretch the posterior capsule. So now I will stop sharing this presentation and I'll go to a quick video of Clubfoot, and then we'll talk about how to fine-tune Ponseti technique in other conditions. So I'll just stop share now here and let me share screen. So can you see this video now, Joyance?
So we can see this folder. We can't see the video being played.
Okay. Now this is playing on my
So you'll have to share that
laptop.
video screen.
Sorry.
So you'll have to in the share screen. You'll have to
I will
share the
stop it
video.
again. You can see this folder, right,
Yes, sir.
Joyance?
Yes, sir. We can see the folder.
Stop. So let me share it again. Okay. So give me a moment and can you see this now?
It's not the video, sir. Only the folder.
Joyance, can you see this?
We can not see the video, sir. We can't see the video.
Can you see the video, Joyance?
No, sir. Sir, in your share screen, the
Hello?
video screen will be separately shown, sir. You can share that, sir.
Hello?
Yes, sir. So now it's the slideshow we can see, sir. Tenotomy protocol slide.
Am I audible?
Yes, sir. Yes, sir. You are audible.
Am I audible, Joyance?
Yes, sir.
Hello?
Yes, sir. Yes, sir. You are audible, 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 sir. Yes, sir. You are au
Yeah. Am I audible, Joyance? So now you are seeing the screen, presentation screen.
Yes, sir. We are seeing the tenotomy protocol slide.
Okay, so I'm trying one more time to share my this thing. I want to show you a video from my desk. So what should I pause sharing, stop sharing this, and then start sharing the screen? Going from. So let me try one more time. Now, can you see the folder? Clubfoot residents and all. Now I'm clicking on Ponseti. Can you see this video now? How? तो ऐसा क्यों हो रहा है? यहाँ दिख रहा है मेरे को. ना मैं वही किया. आई वेंट टू द शेयर स्क्रीन थिंग. अभी मैं, आप देख रहे हो ना वो.
फोल्डर दिख रहा है सर.
हाँ, तो फोल्डर में मैंने डबल क्लिक किया स्क्रीन के ऊपर, ये वीडियो के ऊपर, तो दैट स्टार्ट्स रनिंग इन माय लैपटॉप बट इट्स नॉट कमिंग ऑन योर्स. लेट मी ट्राई वन मोर टाइम. लेट मी फिनिश दिस प्रेजेंटेशन. ऐसा करते हैं. ओके. So can you hear me now, Joyance? Please let me know.
Yes, sir. Yes, sir. We can hear you.
Joyance,
Yes, sir.
can you? Yeah, then you tell me, no, why you're mute. Because I'm not able to gather that you are listening to me.
Yes,
Okay,
sir.
fine.
Even when I'm saying, I think it's
Okay,
network
no
issue.
problem. Yeah, fine. So I hope you can listen. I could not play that video, but let's go through the further steps, and then I'll try again one more time if I can share this video. Probably my network is not very good in this place. So then comes the splinting once you correct it, and splinting protocols are there are different splint designs. Like Ponseti Light is available in India now, and the DOP splint where the child can crawl is also there. We When I came back from Iowa in 2006, we didn't have these options here, and we have made our own version where you can increase the angle, decrease the angle, you can telescope and increase the size of the bar based on the shoulder width of the child. And it's a like mini AFO with a hip molding. And we have been using this for now 2006, and it's now 18 years. What is important though is the compliance with the splinting rather than the splint design. That's what I feel. And the correction of foot, that is more important. The splint protocols are for first 3 months, we advise to wear the splint for 23 hours a day. And then gradually we reduce the splint hours. At 1 year, child wears at night and nap time. And at 15 months onwards, child should wear it at night time till 4 years. And we have seen that splint compliance is extremely important to maintain the correction. We have many examples and thousands of children you all would have treated. And why I've shown this is one of my friend pediatrician's child, and she's very close to us. At 8 weeks, she got completely corrected, and at 8 years, she was a dancer. And recently, I was invited in this Arangetram or Bharatnatyam function as guest. She's 18 years. So clubfoot correction through Ponseti gives a lasting correction. But many a times you will see some atypical changes in presentation. For instance, this boy with hyperextended great toe and chubby skin at the top, and you will feel that the tendo Achilles is very tendinous. right up to the proximal 1/3 of the calf. And if you look at their bottom, the plantar crease, which usually lies on the medial side, is now extending all across to the lateral border of the foot. And this is, as we know, it is complex clubfoot or atypical clubfoot. And Dr. Ponseti has described a modified technique where he corrects the hindfoot and forefoot equinus with the help of a two-thumb technique. And you can refer to that paper. And uh, these feet are apparently short, and there is a tendency of slippage of cast if you don't mold them well. So one such very severe case came to us with 7 plasters slipped off, and this is a real severe complex clubfoot. If you get X-rays, you will realize the forefoot and hindfoot equinus. In this patients, the supinators are weak, and so if you externally rotate, you will see the passive external rotation increases very quickly in couple of plasters. If you keep on doing external rotation, they develop midfoot valgus deformity. So you have to judge by looking at the sole, and this is complex clubfoot, and you don't have to do much of external rotation. We could correct this by modified Ponseti technique, and after 4 or 5 plasters, you can see this. And this is how in a walking age. So complex club feet patients can be also treated by modifying the existing Ponseti technique. Many a times families would ask that the child has clawing of toe or the great toe going in, and should we do some treatment to this? So this is to grip the ground, and this is not the true deformity. Always ask them to wait, and eventually this will improve. The toe adduction or clawing is in order to grip the ground. It does not need treatment. Many a times you will see very stiff club feet, while the deep uh, crease, posterior crease is extremely deep. And many a time there is absent of any crease, the heel is almost flush to the lower leg. And you will see that you are not able to do passive external rotation anymore. Now, this child, after 7 Ponseti plasters, it came only up to neutral, and it was not getting further corrected. Couple of plaster slippage. You can see erythema and redness. Jose Morquin do say that this is a compartment or tight compartment syndrome kind of picture of the leg. But in these cases, you see that the tight heel cord is a constraint or restraint of correction of external rotation. And I have performed early T8 tenotomy. Usually we perform T8 tenotomy only talocalcaneal joint gets unlocked. But in this condition, where the TA is so tight that it is restraining your external rotation, you have to perform an early tenotomy. Now you see what happens when the TA is completely released. The distance between the distal tibia and calcaneum increases so much, and so a tight, extremely tight TA will restrain the external rotation. Then you give plaster, and this helps in allowing molding of your plaster. It prevents slip off, and it instantly corrects the external rotation. You see like this. And the dorsiflexion also improves. Many a times you need to repeat a couple of casts to take the dorsiflexion to +10, +12 degrees. If you see a child with single toe clawing, rule out neuromuscular cause and always check the spine. This is plantar flex toe or dorsal dimples. These all are signs of common peroneal nerve palsy, congenital common peroneal palsy, or sometimes they have spinal dysraphism. The technique is the same. The only thing is they need a long-term bracing, and many a times they have foot drop gait as they grow, and we advise a daytime AFO also. But and you will see the calf will be extremely thin in these patients. They at times also have some limb length discrepancy, but it is good for them because it helps in clearing the grounds. If you try to make them equal in length, they would drag and trap while walking or running. Always check spine, myelomeningocele or spina bifida. club feet. Also here you can correct, but remember that these are intrauterine club feet with a weakness of ankle dorsiflexors and everters. So you, after correction, you have to splint them. You have to check them frequently and tell family that this child would need orthotic support for long. We see many a times club feet in arthrogrypotics with hyperextension of knee and dislocated hips. So here you start with a knee correction because you need knee to be flexed at least at 70, 80 degrees to successfully put the foot plaster. So you correct cavus gently and then you go above the knee to correct the knee hyperextension. You might need to do a rectus stenotomy at some point, and then you come on the foot correction. These are challenging problems, and we do DDH treatment only if child has walking potential at 1 year. So take home message is to rule out postural deformities and no surgical treatment for timely presented club feet. Recently, I did one posteromedial release in a child with very severe arthrogryposis. But for last 7, 8 years, we have not done for 10 years I have not done PMR, posteromedial release, and examine the child for associated cause and treat accordingly. So I think I finished my presentation here, and I'll stop sharing my presentation and then try one more time if I can uh, present my video. Okay, Joyance?
Yes, sir.
Hello.
Hello. Yes, sir.
Can you hear me, Tashfin or Joyance? Please let me know.
Yes, sir.
Yes, sir, we can hear you, sir.
Oh, yeah, Tashfin.
Yes, sir.
Yeah, sorry. I'll try and share this video one more time, and if we cannot see, then we'll discuss. We'll start discussing. Okay.
Okay, sir.
Okay. Hmm. Let me know if you can see the video. Okay.
Okay, sir.
Can Can you see the video
Not
or
yet, sir.
not?
Not yet.
Hmm.
No, sir.
Yeah. So something. Okay. Anyways, this video is running on my laptop, but not on this. Uh, I cannot share somehow. Let's stop my talk here, and I will be able to happy to take your questions if you have.
Yes, sir. So the questions, so Dr. Kaiser has asked, in case of early tenotomy, do you do retenotomy? If yes, then at which level?
Yeah, that's a good question. I had a few instances that after doing early tenotomy, the dorsiflexion, uh, it did not improve, and you do couple of casting, and then you see that the TA is reformed again. I have done a retenotomy at proximal level, maybe after a couple of weeks of first tenotomy, but that was uh, seldom required. We have to accept that the patients like complex club feet or uh, one with arthrogrypotics or this stiff club feet, the passive dorsiflexion range is not like plus 15 degrees. If you get about 7 to 10 degrees, then you have to accept it.
So,
Yeah, if we
so any comments on accelerated Ponseti technique?
Yeah, so accelerated Ponseti technique is used when the patients are from far and you want to do classing at every fifth day. Now, this was introduced by Dr. Ponseti and colleagues because they had a lot of patients coming from Europe and they could not afford staying back for long. And so they tried to do it 5 days. What we need to do cautious about while doing rapid corrections, you always check the skin and inquire with family whether child is cranky at home, because many a times if you do casting every fifth day, they develop edema and a tight compartment type of picture. There you have to stop. Otherwise, every fifth day you can do casting in an accelerated way. Make sure that you are not producing a lot of edema.
Yes. So, Professor Anandpal has asked, which is the highest age of percutaneous stenotomy?
Yeah. So with time, you know that this stenotomy will give you sufficient correction. Uh, for instance, the patients with neurologic club feet, although they look very severe, once you do the tenotomy, they get corrected more compared to the idiopathic stiff ones. And at some point, you will learn that this looks very stiff to respond only to tenotomy. And if you have doubt, you can perform a conventional open posterior release where you can do Z lengthening of heel cord and do capsulotomy as well. So we have done TA tenotomy in 3-4 years patients as well. The older children with very stiff club feet, there we feel that the equinus is too much and heel cord doesn't feel very tight or very prominent. There you know that there is certainly the hindfoot or capsular contracture. So there we go for an open formal release. What are other
So,
questions?
Tashwin has asked about modified Ponseti's technique.
Yeah, I purposefully have not shown because of time constraint, but you read that paper, that's very nice technique. What he does is you hold the foot with your middle fingers, you hold the heel and you keep your index fingers around the tailor head and the thumb on the plantar surface, and you do this maneuver. So you are pulling the heel down and you are pushing the forefoot up. So that is modified Ponseti technique. One thing which need to be known is in complex club feet, sometimes they have absent dorsalis pedis artery. So if you do a quick correction of cavus, there will be blanching of the toes, and if dorsalis pedis is absent, you may lose circulation. So always keep the toes open and look for the blanching, and blanching should return to pink toes in 1 minute. If not, then you remove the plaster. You understand what I mean? When you correct cavus very fast, you may put the plantar vessel in spasm. So always look at the toes. That doesn't happen in idiopathic club feet, but it can happen with complex club feet.
Yes, sir. So another question, what could be the reason for iatrogenic lateral crease and how to correct?
Yes, as I told you, in complex club feet, the main element is forefoot and hindfoot equinus, and inverters are weak or supinators are weak. So you will see that your passive external rotation corrects just in 1 or 2 plasters very easily. And if you keep on doing external rotation correction, because you are trained and you are told that the tenotomy can be done only at 60 degrees of passive external rotation, you keep on overcorrecting the foot, and that correction is happening at the midfoot level. So now there will be a lateral crease at the midfoot level, and that is an iatrogenic. So we always need to check the talocalcaneal relation after every plaster. And as I mentioned earlier, many a times in 20 degrees of external rotation also, the talocalcaneal joint gets unlocked. And then you should stop doing further external rotation and go for T8 tenotomy.
Yes.
Please mention the areas. So let me take the questions. What is the highest age?
Me.
What could be the reason of an iatrogenic lateral crease? Relapse. In case of relapsed clubfoot with flat top talus, how shall we correct the equinus if even after posterior open release we reach up to neutral? Yeah, so that's a real issue. If you are good with frames, one way is to correct with a frame, and if you don't want to use frames, one can do a supramalleolar dorsal closing wedge osteotomy to give about 10 to 15 degrees of correction. Those are the two ways. They are difficult and challenging problem where the equinus has been neglected for pretty long time. Yeah, so you can stage it. Many a times you feel that this equinus is severe and this will not get correct, but once you do a conventional posterior release, you might be successful. If it is not successful, in second stage, you may do with a frame or with a supramalleolar level. How to correct midfoot break in a clubfoot baby? Yeah, if I assume that you are asking if in a complex clubfoot it has ended up into valgus, then you have to reverse it. You know, if it happens, so we receive many such patients. Then you have to put a plaster with forefoot and little bit of adduction and inversion, and you have to align the midfoot. And once it is done, then you employ your modified Ponseti technique. What I have done in some of these patients is when you employ this modified Ponseti technique, you try to correct the forefoot, bring it a little bit inversion and adduction with the help of your thumb, and then you push it up, and in a couple of classes you will see that lateral crease will disappear. Please mention the areas of molding on plaster, especially in atypical type of and plumpy leg. Yeah, so I remember distinctly Dr. Ponseti used to say, and he will put his fingers behind the ankle, you know, in order to mold. And he would say this is heel pulling maneuver. So in complex or plumpy clubfoot, you try to mold the heel cup with your fingers behind and try to bring it down. At the same time, your thumbs are at the plantar surface of first and fourth or fifth metatarsal head, and your fingers are just palpating the talar head that, it is stabilizing it. So all this correction are happening at two levels. And the more chubby child you have to be more cautious about molding. What I see sometimes people roll lot of layers of soft roll, and um, they finish the plaster first, and you have to have thin layers of soft roll so that you can mold the heel well, and you have to feel and palpate the bony prominences. Along with spatial areas of molding, what are the precautions to prevent plaster slippage? Well, one area is you have to apply the plaster in about 100 degree of knee flexion. Although it has been said that one should not do more than 90 degrees, but we have done in about 100 degrees in this cylindrical calves, because that can lead to slippage. So I think, Joyance, do we have any other question?
Sir, we don't have.
Okay. So thanks, and sorry for that glitch. I know I will learn now how to share my videos. And maybe I can share this video on fellow stitching module once I'm back. So thank you very much, everyone. Hope you learned something new today. Have a good day.